Um, there's, in my usual fashion, there's about 5 or 6 points that I want to get across. And I think the very first thing is that heart attacks happen perioperatively. Second thing is when heart attacks happen perioperatively, they're bad. Unfortunately, they're a bit underrated in that we don't seem to take them as seriously as heart attacks which happen prior to surgery or coming into the emergency department. We don't take them to the cath lab as quickly or as often. We don't anticoagulate them as often, and consequently their mortality is actually probably about 40 to 50% higher, morning safety, 40 to 50% higher than the average myocardial infarction which happens in a patient coming into the emergency department. Third general concept is our intuition, as one of my physics profs in university told me quite elegantly when he was talking about angular momentum, is that your intuition quite often lends you very much astray, and science really should drive your decision making. And poise one, as we all know, was to test our intuition that simply beta blocking everybody would be a great idea, and we found out that wasn't necessarily the case. That doesn't mean that some patients don't get better with judicious bradycardia when it's applied appropriately. So you really can't take away from the clinician's discretion. And then I want to close out with the managed trial, which is going to look at the use of an anticoagulant in the treatment of myocardial infarction, which happens after surgery. And the rationale for that is anticoagulation in general improves the outcome after myocardial infarction. We saw this with heparin, we've seen this with low molecular weight heparin, and we've seen this with Coumadin. And hopefully we'll see some of the same kind of thing with this. So that's more or less the story. So now we'll get into the fine print. So we'll begin with this usual disclosure. There's no money involved here. The VISION trial was published in the Journal of the American Medical Association last summer. This is a landmark which is going to drive changes in our practice for a substantial period of time, probably for most of the rest of our careers. We'll talk a little bit about the pathophysiology of peri-op MI, prevention of MI, and management of MI. And, you know, sometimes it's helpful to have an anecdote. Start with an 86-year-old male, has hypertension, has a radical neck dissection. Actually, it was a parotid gland tumor that he had. He had a modest amount of fluid intraoperatively, and he responded to hypotension that happened. And unfortunately, immediately post-operatively, he had a troponin, which actually peaked at 9. So let's keep that guy in mind. And then on a macro level, this is a substantial issue, really. There's many surgeries done worldwide. We do quite a few in Edmonton. There's an enormous bulge of people that are approaching 60, 65, 70 years of age, and there's this light coming down the tunnel, and it's like it's coming faster and faster and faster. And you know, we're just kind of going, I don't see anything, you know. So we're going to have to deal with it at some point in time. The thing about post-peri-op MIs is most of us don't even know we're having them when we have them. Notice I just kind of shifted into the we. So when patients are having them, they don't know that they're having them, but guess what? Sooner or later, all of us become patients. And they're asymptomatic, and they're hard to tell as far as standard, what was standard testing. But I'm going to propose to you that we have a new standard test, which is not quite just, I'm not saying don't do the clinical exam and don't do a cardiogram. By all means do the clinical exam and do the cardiogram, but there's something else that we should do, and that's a troponin. And you'll see why. And one of the major objectives of VISION was to say, okay, what's the simplest, quickest, easiest, most reliable way that we can determine whether a patient's had a peri-op MI without arguing about it too much? So this was an international cohort study designed to evaluate that question. We took all comers over age 45 who had enough surgical injury that they required a 24-hour hospital stay. So it's not just kind of flaky, well, you know, I just don't feel like driving home today. They had to have enough that they needed an intravenous or they needed parenteral narcotics for whatever reason, or they had enough diabetes and hypertension, et cetera, that they mandated a 24-hour hospital stay. And then we took everybody in those particular domains, elective and urgent, during the day, during the night, and on weekdays and weekends. And it wasn't really horribly onerous to record all these patients because we were able to get ethics approval for a post post-admission deferred consent. Okay, so we were able to enroll them and then give them the right of first refusal. Okay, so this was primarily an observational trial, but basically if the patient came in and had their lab chole at midnight, we could enroll them, do their troponin, and then get their consent the next day, which was basically they had their right of first refusal to say we collect or don't collect our data. And as it turned out, most patients were compliant with that. They just basically said, sure, you're just checking blood work, it's no big deal. That was actually vital because you'll see that emergency surgery actually is a major multiplier for mortality. So globally, we're looking for 40,000. Vision is almost complete. The data you're going to see is based on the first 15,000, and the rationale for that is we switched the type of troponin assay during it because we came up with a more precise assay. And I think everybody should pat themselves on the back. We actually recruited 2,000 patients here, you know. So of those 15,000 that were published in JAMA, we have a big chunk of that, which is both good and bad. On the one hand, we participated. On the other hand, the data is concerning, okay? We can't say it's all those people in South America or those people in Hong Kong that just weren't looking at their patients. No, it's not quite so simple. So we measured troponins on post-op day 1 and day 2 and day 3, and we initially started with the 4th generation troponin T. Right off the bat, we do troponin I's here, and the reason we do troponin I's is because it's bundled with another set of lab work or lab assays that our laboratory buys. It's about 50-50. There's a bit more sites that actually do troponin I worldwide than do troponin T. But troponin T is probably the better assay because it has a smaller coefficient of variation at 2 standard deviations below the mean. So that if your troponin T is significantly elevated, it's significantly elevated. There's no wobble room. It's not kind of like, well, you know, maybe the assay's a little bit unreliable. Troponin T is bang on. It hits the target every time, okay? So we stopped recruiting in January 2011, and we had 99.7% of patients who were followed up completely. All right, so a few descriptors. Half of the population was below retirement age, half of the population was above retirement age, and this is probably a reasonable description of the patients that we deal with on a regular basis. These slides will be posted to our website, so you can digest them a little bit later if you wish. But this is, it's a fairly common mix of, previous heart failure, previous coronary disease, and some patients with no risk factors whatsoever. Okay. Now, as far as the type of surgeries that were included, about 1 in 7 was either urgent or emergent. They basically just were unscheduled. That was the definition of urgent or emergent. Okay, emergent was something which needed to be done within 24 hours or less. And our makeup was, orthopedic, general urology. Nothing terribly surprising. Now, the numbers that matter. The most significant risk factor for dying was age. So that's other than having emergency surgery. So their first recommendation from the study is that please avoid aging. So, okay. In the absence of that, you see the usual suspects: congestive heart failure, recent history of atherosclerotic disease that was symptomatic, stroke, peripheral vascular disease, and COPD, all statistically significantly correlated with death. But age, and the older you get, is the more significant predictor. And of course, there's the bulge, and this is the bulge of people having cancer surgery, okay, and orthopedic surgery, sometimes for symptomatic reasons and sometimes for survival reasons, okay. Now, the interesting thing is troponin was a much better predictor than any of those risk factors, okay. So the single post-operative troponin, if it's elevated, it's bad news, okay. It means that you've suddenly multiplied your risk of dying, okay. So this slide takes a little bit more to digest. Let's begin with, overall in those 13,000 some odd patients earlier on, if you have no troponin elevation, you still have a 1% mortality rate, okay? So this is all not all that surprising because some of these patients are going to be emergency perforated valves, okay? So even if you're 45 and you have a perforated valve, there's a mortality rate associated with that.
That's
okay?
not cardiac mortality, that's all-cause mortality.
That's all-cause mortality, yeah, okay?
What's the cutoff in the lab for normal, again, for troponin T?
For troponin T was 0.02, okay? Right. And for troponin I here it's 0.15, and we have a little bit of wiggle, like 0.15, the lab tells us we're not really sure it's 0.15, it may actually be up to 0.2 to 0.25. Above 0.25, it's definitely elevated here for troponin I, okay? So everybody's got a 1% mortality rate. If you have a statistically significant elevation in troponin, you've quadrupled your mortality rate. Okay. If you go up to 0.03 and subsequently, if you have a massive rise in your troponin, there weren't that many patients, a total of 142 that actually had that substantial rise in troponin, but 24 of them died, mortality rate of 1 in 6. Yeah.
Do you know, Mike, off the top of your hand, what the troponin I would be greater than 0.3? Just
Yeah, at the 0.3, you're probably looking about 10, just like Mr. T.I., our anecdotal patient here. Okay. You also die more quickly the higher your troponin is. Okay. So intuitively, we kind of knew this, but now we really know it on a fact-based basis. Not only that, we have an assay here which automatically selects out a very high-risk group. We don't have to say, oh, well, they're 80, they don't look good, they got a bad haircut, or, they've got a multiplier, the Detsky modifier, the Goldman index, where, you've got peripheral vascular disease, and you've got a couple points for that, and you've got urgent surgery, you've got a multiplier for that. If you just do the post-operative troponin, right off the bat, you stratified your patients, okay? So this then segues into a recommendation for monitoring post-op by the European Cardiology Society and by the American Cardiology Society that basically as a standard of care, we should be in the over 65, just 65-year age group, just measuring troponin on everybody, okay? And if you're between 45 and 65, if you have vascular risk factors, we should also be checking out your troponin. The reason for the 65 cutoff is that the age being highly correlated with death, okay, there's a prevalence of vascular disease which is substantial in the over 65 population. That's just because you got to die of something, okay? Even if you do your 25-mile-a-day run and you swim and you da-da-da-da-da, you still get hardening of the arteries. You can't help it, okay? Most of us in this room have it, okay? Now, the other bothersome thing is that patients didn't always just die in hospital. So this is the other sleeper here, right? We think that, okay, they're kind of hunky-dory, they slip through the first 2 days, no big deal. And then we get the Met call 5 days later. It's no surprise. Guess what? We have the numbers here. A 1/3 to 1/4 of patients die after they leave hospital, okay, within the first 30 days. And that mortality continues to be high in the first 365 days. So in conclusion, overall risk is about 1%, and that's with normal troponins. Any elevation in troponin will bump that risk up to about 4% or higher, depending on how high your troponin is. So the basic conclusion is that any troponin elevation is a significant troponin elevation. It's something you don't want in your bloodstream. Okay? And over 45 with vascular disease, you should be checking troponins. Over 65, just check troponins on everybody. Okay, if they have a 24-hour hospital stay. Now, if they're coming in to have a cataract done, this wouldn't apply, right? Because that's really low-risk stuff. It's kind of in and out, okay? Some of those patients are still going to die, but we really can't prove that mortality is actually significantly elevated by the surgery. Surgery, in this case, is also a risk factor for death, okay? Okay, so prevention. We all heard about POISE 1. POISE 1 was the idea that, well, if we beta blocked everybody, it'd be a great idea, but just to reiterate, we did find that we reduced all-cause cardiac events with metoprolol exposure, and we actually reduced myocardial infarction with metoprolol exposure. But unfortunately, if life and death mean anything, we also increase mortality with metoprolol exposure. Ergo, we can't just put metoprolol in the drinking water. It's not quite that simple. POISE 3 is going to be looking at a selective beta blocker which drops your heart rate without dropping your blood pressure. So this is going to be nice and interesting. And it's undergoing evaluation right now in terms of pilot testing, okay? But we're not there yet, and certainly we wouldn't want to, dissuade the astute clinician from modifying the hemodynamic risk profile in the appropriate patient, okay? But systematically, the recommendations from the American College of Cardiologists that we basically beta block everybody clearly were jumping the gun, okay? So I think the other recommendation from this kind of data is that you really need to have systematic data before you make a broad-based population recommendation. You can't just go on your intuition and on your gut instinct, okay? So a couple other sidebars that we learned from POISE 1 is that with a myocardial infarction, you had a much more complicated life, okay? That you had a much higher chance of developing heart failure, a much higher chance of having a cardiac arrest, and also a much higher chance of having a stroke, okay? So if in and of itself you didn't believe that treating or preventing a myocardial infarction was a great idea, or treating myocardial infarction is a great idea, surely we wouldn't want to live with heart failure or have a cardiac arrest or a stroke. Okay? So it's not just that you're more likely to die, you're also more likely to have a complicated life. And your mortality rate is substantially higher than that of the untreated or the treated myocardial infarction that comes through the emergency department. Now, the motherhood stuff. Metoprolol made patients more prone to have hypotension and bradycardia, just about doubling the risk of hypotension and tripling the risk of bradycardia. And unfortunately, both hypotension and bradycardia were correlated with dying and were correlated with the other complications. So that old adage about avoid hypotension, bradycardia, and hypoxemia is true. Okay, I mean, it's fair. Okay, but the thing which is kind of the snake in the grass on this one is that we monitor patients very closely intraoperatively. There, okay. I mean, you've got minute-to-minute control, don't you? All of a sudden, they go to the recovery room and it's just hunky-dory fine, and then they're off to Never Land, and we just kind of hope for the best. But we know ischemia is silent. Okay, we know that ECGs are somewhat helpful, and we know that the risk carries on for 30 days. Okay, now it does have a parabolic decrease, or I guess I could call it an exponential decrease over those 30 days. But nonetheless, it's not just intraoperative risk they face. Okay. So the elephant in the room is, how do we actually look after these patients post-operatively? Well, maybe we can kind of develop some kind of relationship between the vision results and our risk profiles, and that to say that, okay, if you have a post-operative troponin elevation, we really should be attending to you with more vigilance, because you have a much higher risk of developing those other complications like heart failure, stroke, and death. Okay? And on the other hand, if your troponin is not elevated, then we can stratify you into a lower risk or a lower intense monitoring situation. I'm not saying that these patients need intensive care, but they need a circumstance where they can be monitored to avoid the hypotension and the bradycardia, which are associated multipliers with those other adverse outcomes. Okay. Now, do we have that technology? Yeah. Does it cost money? Yeah. Is the hospital going to want to buy it for us? Well, I'm not so sure about that. But this is the kind of data which leads to this, which changes this from being a theoretically persuasive thing to be a more demonstrably persuasive thing. Okay. And there could be a cost benefit, because treating patients with heart failure and stroke in the long term is not cheap. Okay, if we can prevent that from happening, that actually may translate into a reduction in costs. Okay. ACE is thoughts on ACE. Do people hold ACE inhibitors here for the most part? Yeah. Okay. So it's kind of another. This is another interesting observation, is that POISE started out just with beta blockade, and it's translated into a lot of other changes in practice. Okay, so like once the genie's out of the bottle, it goes in many, many different directions. It's quite interesting. POISE 2 is underway. It's looking for 10,000 patients worldwide. Currently, as of today, it's actually at about 8,000. The U of A has almost got 100, and it's basically aspirin and/or clonidine versus placebo. Okay. Both of those drugs have approximately 3,000 patients studied in meta-analyses, which kind of justify the argument that this is a worthwhile study to do. And you may have had some patients in POISE 2 that have come through your operating rooms. Hopefully the thing will be done by September, October, and we can have a systematic answer for that, and then we can move on to POISE 3 as far as the prevention trial is concerned. So, kind of as I was alluding to, that how do we treat these post-operatively? We probably should have, if we can employ systematic troponin assays in the at-risk population, which is basically the over 45 with vascular disease, over 65, all comers, then we should be able to selectively stratify those who need more intensive monitoring. Okay, basically looking for their heart rates and their blood pressure, and then have that data dumped to a database where we can actually have a person operationalized to introduce a change in their management. Back to Mr. T.I. So all's not quite rosy, though. So on a systematic basis, that's one of the things to consider. But Mr. T.I., with his peak of troponin, for some reason, it's reasonable to start him on aspirin on a beta blocker. For some reason, he was given heparin empirically. Okay? And unfortunately, this was not done with discussion with the attending surgeon. Big problem. Okay. Not a good idea. Anticoagulation is not benign, especially when you're over 80 and you've just had surgery which involves your airway. So he was heparinized, he developed an airway obstruction, and he did not do well. Okay? So it's not a benign phenomenon. Okay? So post hoc, I think the recommendation here would be is although this might be an appropriate therapy, we don't really need to aggressively jump the gun on anticoagulating these people immediately as soon as the troponins up. Okay? You kind of have to look at the big picture. Okay? And after all, the risk does carry on for at least 30 and more likely about 365 days. So that first 2 to 3 days, although it's a higher risk profile, you can keep them monitored without systematically anticoagulating them. So in conclusion, MI is common, it's bad, it's worse than non-operative MI. We don't treat it as intensively, we don't take them to the cath lab as frequently, we don't anticoagulate as often. They're not as simple, they're not as straightforward to manage as patients who come in with myocardial infarction off the street. Most of them are like the snake in the grass. They don't tell you they're having infarct, they don't tell you they've got chest pain, they don't have ECG change. The single most useful thing is probably routine troponin. We have to be careful with our intuition. All right, so moving on to the managed trial. If heart attacks are bad, preventing them is okay. That's a great idea. So we did POISE 1. We found out, okay, metoprolol is not so hot. Maybe aspirin and clonidine would be better. But maybe we should be doing something to treat myocardial infarction after surgery if we have the tools or the capacity for it. So cell injury is caused by ischemia. Fair enough, okay. So we kind of can't get away from this without developing a new syndrome. We thought of a few different names. Some of these really aren't appropriate for mainstream consumption, but we settled on myocardial infarction after non-cardiac surgery. We'll call it a MINS. Okay? And I know this is being taped, so I won't really tell you some of the other names that we kind of thought of. Okay? So a MINS is a troponin elevation that happens after surgery that is not believed to be due to something else. Okay, so we don't think it's a PE, it's not due to septic shock, it's not due to cardioversion, and it's not confused by renal insufficiency. Okay, so it's due to an ischemic etiology. Okay. Now, looking at those 15,000 patients in VISION, in the 262 people who died, if you look at the multipliers, or the closest associations with mortality, if your tropes are 0.04 and you have a clinical feature, okay, well then that's pretty straightforward. You have a very, very high likelihood of death. But we could be a bit more refined. We could be a little bit more sensitive and a little bit less specific, okay? And we can still reduce our threshold for treatment with troponin T, which correlates roughly to a troponin I correlation of a troponin I level of about 0.25 to 0.3. Okay, so it's about a 10-fold difference. So roughly speaking, this would be the troponin T cutoff for definition of a MINS. Okay. So going back to the VISION data, just to reiterate, age is bad, avoid it if you can. Emergency surgery is particularly problematic, and we know that because patients don't come in prepared, they come in dehydrated, they come in with various other stressors associated, okay? And we don't have the ability to optimize them, we don't have the ability to defer them, okay? Cancer surgery is a problem, patients are procoagulant, and neurosurgery actually is a fairly significant risk associated with that as well. But even with those risk factors identified, a troponin elevation is still, at that particular level, is still a very, very significant risk factor for mortality, okay? So the simplest little thumbnail sketch to take away as far as post-operative modification of treatment is concerned, if the patients are septic or if they've had strokes or they had PEs, they have substantial multipliers as far as risk of mortality is concerned. We're engaged in another trial called Neurovision to look at the prevalence of stroke, and one of the things that we may do is be able to find ways of modulating the likelihood of having a stroke perioperatively. But we're not really there as yet as far as therapy is concerned. We can't really prevent sepsis. We can certainly institute treatment early, but focusing on what we can do and what we can do in this room and in our main working environment is look at ways of preventing and modifying mortality after MINS. MINS is not a minor complication. It substantially multiplies the problems with the rest of your life. You're more likely to have a cardiac arrest, congestive heart failure, stroke. And that risk carries out for a long time, okay? It's not as if you can just kind of puff the hands and hit the road, okay? That risk multiplies your likelihood of dying in the first 12 months by about 5, okay? So I guess we've kind of already answered that question, so I'll just skip through that here. And we'll end with both the European and American cardiology societies recommend routine monitoring of troponins after surgery, okay? In those risk profiles that I talked about, over 65 or 45 or more with the vascular risk factors. So taking another little sidebar, taking a detour here for a moment, a couple other things we did from POISE is we looked at the use of statins, aspirin, and blah, 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 blah. I mean, with 8,000 patients, you're not going to just let the data go to waste, are you? So we did find that aspirin's not a bad idea, statins are not a bad idea, ACE post-op, if you've had an MI, is also not a bad idea. The problem is we still have a long way to go for compliance, and this is prescription, okay? So that there's some inattention to this phenomenon, okay? That you got through your surgery, everything's okay. Well, not so much, okay? So we've got a long way to go on this, and this is educational. Okay, it's not as if we can do a trial and say, okay, we're going to prescribe aspirin randomly selected versus placebo, because there's enough data to say that if you've had an MI, you need aspirin. Okay, we're just not using it. Pathophysiologically, this is an important concept here, is that we learned from POISE that we can't just willy-nilly do work with our intuition. We need to know a little bit about the pathophysiology. We thought that bradycardia was a good idea, and I would certainly say that judicious bradycardia in the appropriately selected patient by the astute clinician remains appropriate, okay? But we're talking about broad brush population recommendations in this context, okay? So for POISE, we try to identify risk factors. You're 45 or more with vascular risk factors, et cetera, et cetera, et cetera. Pathophysiologically, we found that a lot of the patients who had MIs didn't have atherosclerotic heart disease that were these plaques that were stuttering in the wind. This was from autopsy series. About 2/3 of patients did have significant clot in the coronaries on autopsy series, okay? So clot is highly likely to be operational in those post-operative MIs, but not all of them, okay? So we begin with a population study, but then we can refine it as time goes by to something a bit more specific and fine-tuned to the exact patient, okay? But that sort of fine-tuning is probably 10 to 20 years down the road. We don't have the technology, we don't have the information to know who is having exactly what kind of MI right now. Those type 2 MIs where you have a supply-demand mismatch, some of those are actually due to clot, okay? But we do know that if your troponins are up, you have a problem, okay? Our treatment may refine as time goes by. So a lot of patients have clot, and the more likely you are to have a clot, the more likely you are to die fast, okay? Now, why an antithrombotic? Observationally, we did learn that aspirin after a troponin elevation reduced your mortality, and that kind of proved kind of the obvious, but this is actually the best post-operative data that's out there. This is actually one of the few post-operative evaluations. It wasn't a randomly selected population, it's just observational, but nonetheless, it pretty much proves the point. Aspirin's a good idea. Now, moving that along, so aspirin's okay. Aspirin probably works on a population because it reduces clot prevalence. In those patients coming in through the emergency department, acute non-STEMIs, heparin works, heparin plus aspirin works, okay? And heparin adds a benefit to aspirin exposure, okay? Low molecular weight heparin also reduces the risk of mortality in hospital and for the subsequent year, okay? So carrying on with that theme, the long-term impact is also beneficial if you've had an MI and you're already on aspirin, okay? You still benefit with further anticoagulant exposure, okay? You have, in terms of meta-analyses after acute coronary syndromes, a large number of patients already published worldwide which shows reduction in death, MI, and stroke with Coumadin exposure. There is an increased risk of bleeding associated with that, but it balances in that the odds favor treatment with the anticoagulants. So we have a lot of lines of reasoning strongly supporting that anticoagulant exposure would be beneficial even in the postoperative patient. Clearly not Mr. TI, because we can't just jump the gun on them. We have to select, okay? And we also have to selectively expose once the rest of the bleeding risk is dissipated, okay? So which agent would be appropriate? Well, dabigatran is a new drug, relatively new. It's actually been around for about 12 years. And one of the most, one of the largest trials of 18,000 some odd patients is RELY. It was published in New England Journal in 2009. And it looked at Coumadin, dabigatran 110 and dabigatran 150 for the treatment of atrial fibrillation. Okay? And its outcomes were stroke, mortality, and myocardial infarction. And across the board, dabigatran 110 basically came out as being the best medication to be using if you have atrial fibrillation. It had the lowest likelihood of intracranial hemorrhage, the lowest likelihood of gastrointestinal hemorrhage, and the lowest chance of mortality, and the best prevention of stroke. Okay? The signal, which has been confusing in the literature in the last 12 months, is do or do you not have an increased risk of myocardial infarction with dabigatran exposure? And the best answer to that is that's probably a survival epiphenomenon, in that the patients in the Coumadin group, okay, who died also probably died with myocardial infarctions. The patients in the dabigatran group who survived, although they survived, had a slightly higher chance of having a myocardial infarction, because the patients with the Coumadin group that died are the ones that actually had the myocardial infarction. Okay? So it's a survivor epiphenomenon, if you will. So dabigatran 110 is probably a pretty good comparison to warfarin. Now, as far as warfarin is concerned, if we were to try to bring warfarin to clinical practice right now, today, with its risk profile, with its metabolic interactions, with its multiple drug interactions, we would never be able to get it past phase 1 clinical trials. Okay? That's probably the big problem with Coumadin. Okay? That every antihistamine, every antibiotic has some idiosyncratic or known enzyme cascade interaction with Coumadin. It's a complicated drug to use. Dabigatran has a much cleaner profile and ends up being a much simpler drug to use. If you put the two of them in a side-by-side comparison, dabigatran ends up being much simpler, slightly more expensive, but associated with much fewer complications. Right. So if you were to look at it overall, as far as mortality is concerned, in the RELY trial and in a few others, RELY was the big published component of meta-analyses so far, but there's been a few others, and you end up with a statistically significant reduction in mortality with dabigatran exposure. The epiphenomenon, or the competing outcomes, is the problem that I allude to with the myocardial infarction issue with dabigatran. So managed is going to be dabigatran and or omeprazole versus placebo. So obviously, if you're on an anticoagulant, you may benefit from having gastrointestinal protection, or you may not. And the may not comes from omeprazole is a PPI. It changes your gastrointestinal flora. It essentially obliterates the gram-negative population in your small bowel. Okay? So there's a higher instance of aspiration of gram-negative content. Okay? The older you get, the more likely you are to have chronic nocturnal aspiration. So pneumonia may be an adverse effect associated with omeprazole exposure. Okay? The other funny issue with omeprazole you may or may not have heard of is that there's an association between omeprazole exposure and Clostridium difficile colitis. Okay? So again, carrying on the theme of being careful about your intuition, it's dangerous to make a population recommendation without data, and the population recommendation to sort of give a gastroprotection agent in the setting of anticoagulant exposure is very risky. So this is an opportunity to say, okay, it either does or does not work, because again, broad brush recommendations to use Losec in the setting of anticoagulant exposure may actually be dangerous. Okay? So omeprazole may work or may be beneficial by reducing the likelihood of gastrointestinal bleeding. Alternatively, it may have adverse effects, and we really don't know what the balance is at this point in time. So the primary objective of the managed trial is to determine the effect of these two drugs, dabigatran and omeprazole versus placebo, on the risk of both major vascular complications and upper GI complications. We're looking for 3,200 patients worldwide. The study drug is dabigatran 110 twice a day, 2 by 2 factorial, and the usual sorts of blinding protection exist. Patients are going to be followed up for a substantial period of time, okay, between 6 and 24 months, depending on when they're enrolled and depending on when the trial closes. So to be enrolled, you have to undergo non-cardiac surgery, be over 45, and have a MINS. Obviously, you need to give informed consent. We are excluding women who are pregnant. We will be including men who are pregnant or men of childbearing potential. I don't even know why we say it that way, but we do. So, exclusions. A couple important ones. I think this is among the biggest ones, and this is the problem with Mr. TI that we saw in the anecdote before. Okay, we really still, even though we're looking at broad brush population recommendations in order to attempt to generate the science to guide our practice, we still have to individualize. And if we do not believe it's safe to initiate anticoagulant therapy because of the patient or the patient's conditions or their comorbidities, then it's not appropriate to enroll them in this trial. Okay. Alternatively, if it's okay, you think the bleeding settled down, well then their mortality risk needs to be addressed. Patients need to be on aspirin, and we cannot introduce heparin, or low molecular weight heparin, as a prophylactic anticoagulant here. And if you look at the ACP guidelines, and this was actually illustrative to me too, is that aspirin has the same mortality benefit and DVT prevention benefit as low molecular weight or unfractionated heparin. Okay, so all patients in the managed trial will be on aspirin, and that will be either that or mechanical compression will be the standard of care for DVT prophylaxis. So that was a good learning, but aspirin works just as well as far as DVT prophylaxis is concerned. Another contraindication, obviously, if they have an indwelling epidural or spinal catheter, if they have renal failure, if we're expecting to undergo a cardiac cath anyway, or if we're expecting if they have another solid indication for systematic anticoagulation, if they're already in atrial fibrillation. Okay? So as I alluded to, aspirin works just as fine as anything else. Patients are going to have aspirin, and we can't have heparin exposure. So if you remember nothing else, troponin's bad. Well, troponin's a good marker. Myocardial infarction is bad. Troponin is the single best test we have right now to identify patients who are at high risk. I think we have an opportunity to move outside of the operating room and say, okay, these are patients who are at high risk of having a complication. We might be able to prevent this by addressing their hypotension or bradycardia post-operatively, because now we can identify the ones who are at highest risk. Okay? They don't need bedside, one-to-one monitoring in an intensive care unit, but they need something. We can't just send them off into the woods. Okay? It is recommended that it's become a routine test. This is a systematic population problem. It's going to get bigger the more patients age, or the more the rest of us get older. And the best opportunity we have to do something about it right now is to engage our patients in the managed trial. Now, the general surgeons are on board. One of our co-investigators, as you saw, is Michelle Graham. Two of the co-investigators are Ron Brisebois and David Williams. The urologists are on board, and the orthopedic surgeons are on board, just to say that, as long as the patients have their coagulant or anticoagulant risk, settled down, like if they've had a retroperitoneal dissection, I'm not going to put them on heparin today, okay? But alternatively, once their bleeding risk is settled down, if they've had an MI, and it happens within 5 days, then that'd be the appropriate thing to do, okay? So we're good to go for that. And
How does cardiology feel about this?
well, this is a problem for them too. Like something. They basically have the mind that, okay, something needs to be done, and this is thus something which needs to be done. So they're actually glad that somebody's doing something about it. Okay, is this necessarily the best thing to do? It's better than doing nothing. Okay, yeah. Yes.
Where's the money coming from? It's the manufacturers of the bigger truck.
Yeah, they donated money to CIHR. Okay.
Come on.
No. It's actually, this is actually a grant funded to. They supported a continuing grant just for the administration of the offices, but this is basically they donated the drug. Okay, so it's really about it. Yep, Rex.
I think this is great, Mike. One of the frustrations from working in ICU is the patients come out, they have a troponin bump, you end up getting consulted about it, you call cardiology in case something needs to be done. And then, if you guys have ever seen this, they get this consult, well, it's not an MI, it's supply versus demand. Well, hold on a second, the patient just probably underwent the most strenuous test you can actually have, certainly more strenuous than something that you can do on a treadmill. If the patient was at home shoveling snow with the same risk factors, they would have gone down and got a calf and got all this stuff, but because they've had an operation and they didn't know what to do with it, right, they would just talk it up as supply versus demand, and then they would just ignore it. And the problem was, I think before, is that there was just this huge amount of ignoring a positive troponin in the setting of a severe, metabolic demand on the patient that warranted an investigation, and they were ignoring it. So I think the most important thing of all this is that the cardiologists are going to be very busy investigating a lot of troponins afterwards, because it's much, much greater stress test than anything you can do on a treadmill, right? Having somebody undergo surgery.
I think you're exactly right. And that's why I emphasize the concept of snake in the grass. Like it's, we get our patients through the operating room and we fine tune and we attend to them, and then okay, we have a test, and I was like, okay, what do we do about it? It's not as simple as we can't take them all to the cath lab, okay? We can't put them all in the intensive care unit, okay? But and this problem is getting bigger, okay? So, Tim?
I was going to ask, when is that first dose of dabigatran going to occur?
Okay, so the surgeon has to be happy that the bleeding is stopped, okay? It has to happen within 5 days of the first troponin elevation, okay? Because the reason for that is, frankly, is that if we can wait a while, but if we wait too long, then we're going to lose the signal for the potential benefit of dabigatran, okay?
What's the earliest that it would occur then?
If you say the bleeding stopped, okay, and I suppose, Mr. T.I. was a bad guy because he had a neck resection, okay? Supposing you had ankle surgery, compressible site, okay, and your troponin bumps up to 0.3, and you talk to Gord Golpin, and he says, okay, you say the troponin's up, he knows, do you think the bleeding stopped? You can do that, you can start right now, okay? But as long as the surgeon's happy that it's a compressible site, there's no bleeding associated with it, and that the rest of the risk factors are stable. Okay? So you can start as soon as the tropes are known to be up. Well, yeah, and you have consent. And blah.
No, but the concern that I would have is in situations where, say you have the epidural or the spinal, is that going to impact or?
Yeah, you can't start it with an epidural on board. I wouldn't.
Yeah, and then the return to OR, like that might be one of the criteria that they would use, saying, well, this patient's going to come back. Right?
Then I wouldn't enroll them in the trial. Okay, because we have to have the surgeon content that the surgery's done. Now, sometimes things happen, okay? But as far as you know, they're not likely to come back to the OR, that there's no risk increment associated with anticoagulant exposure, okay? This is just the same as we would to say, okay, would you be comfortable heparinizing this patient, okay? So if the patient has an epidural on board, I wouldn't, right? So, I would say, okay, do we need the epidural or do we need the heparin? Well, then I think you kind of have to judge on a case-by-case basis, but if you really think the heparin's beneficial, then you probably should take the epidural out and then introduce the heparin, okay? Or alternatively, maybe take the patient to the cath lab, but we wouldn't increase the risk exposure.
The only other concern with that, then, is if that is one of the criteria that they would consider, whether the patient would return for additional surgery or for bleeding complications, and those would be the patients that wouldn't be enrolled in the trial.
Right.
That's a population that might be more prone to have
Might be.
complications.
Yep. Yep. Well, exactly. Right. So I don't know how that's going to play out. Correct?
Two things. Just a little play on what Rex had talked about, because you have to cut the cardiologist a bit of slack, because one of the important things about your study-wise has been the fact that you've introduced, of course, medical management. Because you know yourself, if you investigate most of these people with these troponin rises, they don't have critical coronary disease.
Correct. Nor
do they have interventional coronary. So you have to cut them a little slack, because taking people to the cath lab doesn't help you. If you've got a 40% lesion in your LAD, you're still going to have to figure out a medical management strategy.
Which is a very good point, actually, because just because it's only 45%, that just means that stenting's not going to help and bypassing isn't going to help. But that doesn't mean that plaque's not going to rupture.
No, for sure. But point being is that's not an intervention on a bypass, nor
totally.
is it an intervention. So the medical management strategies obviously.
Exactly. Right.
The other thing that's quite intriguing with this, especially in our world, is what do you do after you actually have operated on the heart? Because keeping with what Greg Hall did, years ago in Halifax where we were routinely doing enzymatic assessments on people, and then what characteristics that basically help you with as far as predictability. And one of the things we struggle with is what is the acceptable rise, especially if you have a more sensitive assay.
Right.
What's an acceptable rise in the most commonly done surgical operation in North America?
Yeah.
Bypass surgery or
Right.
otherwise, and especially from our world, like with the diabetic regime now. Of course, what's happened with the wait list, it's just exploded.
Right.
So we're still struggling, and how do you best manage those people after, say, a routine previous bypass?
Well, I really can't. I'm so far out of that world. I'm not even sure the dose of heparin anymore. But what I do think that also speaks to the same kind of concept I was alluding to earlier on. Intuition, broadly applied, is a dangerous thing. So I don't think everybody's the same little widget whatsoever. But in terms of getting an answer as a jumping off point that we can move forward to fine tune, we kind of had it asked backwards in the 90s. We kind of went, oh, this is a good idea. Let's give it to everybody. No. Let's say what happens to most people in the population, and after that, how can we fine tune for the individual? So what troponin elevation in what particular population, troponin is probably the best test we have right now. Is it more important to have a troponin of 5 in the diabetics or a troponin of 1 in the diabetic? I think that's kind of where you're going with this. And we don't have that, but I think that, to me, that's the next step. Okay. Explain.
What you alluded to in one of your slides, just in terms of the whole post-operative monitoring and care. So,
Yeah.
you know, these people who are higher risk, we can talk about putting them on a drug, but if they all get very, very loose post-op monitoring and care, what is that going to help you really? Because the hemodynamics are swinging all over the place and nobody really knows or is looking into that. To me, that's a big issue in all this.
I think you're right, and that's why I'm glad Tim's in the room, because Tim is a person of incredible administrative power.
Thanks, Tim.
But I think that's where this is. It's okay. I mean, we all start out as peons, okay, and then we kind of gather data, okay, and we've gathered enough data to say that, okay, we have this black box that we've dumped patients off to, okay. Now, as far as this study is concerned, you've got basically standard care versus standard care, drug versus placebo. So I'd be content with whatever result we have there because we're comparing standard care. But that's an important sidebar is to say, look, you know, we got a whole population at risk that we just kind of punted them off. That's an issue of where political persuasion is necessary to say, okay, Minister Horn, we kind of need some money here because this is a problem. And if we have some money, then we should be able to prevent some heart failure and some strokes and some deaths from happening, as long as we think that death is an outcome which is worth preventing. Okay, but that's really where this money is, or that money is. Okay, but I think that's crucial because I would not want to be kind of dumped off and just sort of said, hey, you know, looks cool to me. I mean, it's dangerous. Hugh, did you have a question?
No.
Thank you so much for coming. The last thing I want to do is introduce Anita McCoy, who is going to be the research associate on the managed trial. And Anita met Hugh and Rex and Craig earlier on. Anita will be accessible through the locating, and we'll have a little spot up in 8th floor, and I'm sure you'll be seeing Anita more and more.
When do you expect your first patients to go through?
I think probably middle of June.
Thanks, Michael. That's great.
Okay.
Yeah, it's good. Good session.
Have a good day.